Welcome to our webinar series for professionals.
So, welcome everyone to this follow-up webinar at a little bit of a higher level about neurotransmitters with Lyle Ferris. So I'm excited to get to the next level, as most of you probably also are. So anyway, we will do recordings, and we will share the recordings, and we will share the slides as well with you all next week at some time when we get the recording downloaded and cut and ready to send out. So I'm Anne-Catherine. For those of you who don't know me, you probably do now, because most of you, I can see your names, I remember you. I'm a co-founder of Nordic Abortions and DNA Life, which is a group of companies that is, we're very international, and we're just dedicated to treatment strategies in regards to functional medicine and personalized medicine. And we have, if you have a practitioner account with us, you of course have access to the lab tests, that we're discussing now, but also to other lab tests and to genetic testing and supplements as well. And I just want to let you all know that we have a next webinar coming up on the 2nd of May, which is a bit of a different webinar than these 1-hour events are, because it's actually going to be a 4-hour event. We're going to have 3 speakers, and they're all going to cover organic acid oat testing. One part is going to be like an introduction, and another part is going to focus on health in regards to the interpretation of the oat test. And a part is going to be really a deep dive into oxalates and organic acids and how to interpret that. So I really hope you all sign up for that one. We, of course, will record that as well and share the recording, just like with these events. So, but enough from me. Oh no, actually the other thing, for those of you who haven't signed up for our Dubai event on 12th to 14th of May, look out in your mail if you still want to join us there. But the star of the show today is Lyle Ferris. She's a naturopathic doctor, and she's working for Doctors Data as a senior staff physician, and she just loves educating. And we had Lyle here. When is that? 2 months ago, I think, when you were talking.
Yeah, January.
So like basic information about. Well, I don't think it was completely basic. I thought it was pretty. So thank you for that. So for those of you who haven't seen the first one, you can always go back into Nordic VMS or follow the YouTube channel and find that one. And then today it's going to be at a bit of a higher level. So I'm as always excited. And remember, everyone, the purpose of these webinars is also so you can communicate and chat and ask questions in the chat box. I'll try and answer as much as I can. And otherwise, we'll do a Q&A in the end. And remember, we're recording, and we'll share the recording and the slides as soon as possible. So, Lylan, I'm going to mute myself and let you take over the show.
Okay. Thanks, Anne-Catherine. All right, let's share these slides. There we go. Can you see them, Anne-Catherine? Is that sharing correctly? All right.
Looks good.
Well, welcome everybody. Thanks for taking the time to join me today. We'll be discussing what I'm calling advanced neuroendocrine foundation. So it's still sort of basic concepts. It's just maybe thinking about them through a different lens. So as Anne-Catherine mentioned, in January, I spoke with Nordic about the basics of neurotransmitter testing and patient support. It's possible that you guys have already been using that tool with your patients. And if so, you may have had the experience of using targeted supplementation like amino acids to address neurotransmitter imbalances. But you may also have noticed that sometimes your patients don't improve as much as you hoped that they would. And so what we're going to do today is talk about some of the other considerations when neurotransmitter imbalance is an issue. Okay, so today I'm going to address the idea that there's more to treating these cases than just boosting or balancing neurotransmitter levels. We know that things like inflammation, hormone imbalance, stress, dysbiosis, food sensitivity, dysglycemia, and more can sabotage neurotransmitter function. These are the symptoms, actually a small sampling of the symptoms that might drive you to choose neurotransmitter testing with a patient. As you can see, most of these you might categorize as a mental health symptom. But some of these maybe more indirectly are mental health. We may think of them more as like a physical symptom, and that might be things like IBS or chronic pain. But this is some of the things that might drive you to do a neurotransmitter test. Now, for neurotransmitter testing, Doctors Data offers two profiles. This is the NeuroBasic, which is sort of the meat. It's the main backbone of neurotransmitters, the ones that are the most researched. So this gives you information on things like serotonin, dopamine, norepinephrine, glutamate. And I do want to mention this is a urinary test. So it's non-invasive, really easy to collect. This is the comprehensive neurotransmitter profile. It provides a deeper dive. So you get all the neurotransmitters that you would on the NeuroBasic with the addition of some metabolites and also some trace amines. Now, generally, when we think about addressing the imbalances that we find with neurotransmitter testing, we're thinking about targeted amino acid therapies. So, for instance, if serotonin was low, you might consider tryptophan or 5-HTP to address it. We also often use nervine and adaptogenic herbs, as well as methylation and nutrient support. But neurotransmitter testing is not a magic bullet. Each patient necessitates a comprehensive, multi-dimensional approach. When symptoms persist after you've directly addressed the imbalances that you see on testing, you really have to dive deeper. So that's what we're going to talk about today. So, when we think about our patients, they present with symptoms that can be associated with a disease. And what is disease? Really, it's a disruption in the flow of information between cells and organs. And so if we think about some of the organs that might be contributing to neurotransmitter imbalance, there's a very long list to consider. It could be anything that's affected by the anterior pituitary, the thyroid, the pineal gland, the adrenal cortex, the adrenal medulla, the central nervous system, the skin, the pancreas, the gut, et cetera, et cetera. So we really do have to think broadly. I want to start our journey today with a case study of mine. This is Molly. She's 53 years old, postmenopausal, mother of 3 children. She's got a lot going on, really, really busy. So she's not exercising at all. And she's eating what we like to call a standard American diet. So this is essentially a high-fat, highly processed carbohydrate, simple carbohydrate heavy diet. She's got a history of mood concerns, and she knows that she'll soon have an empty nest. And so she really wants to focus on herself as she's moving into this transition. So that's why she came to me. Now, you can see here a lot of symptoms: weight gain, hot flashes, insomnia, fatigue, concerns with her cognition, feeling depressed, feeling anxious, no libido, a lot of gas and bloating. She has ankylosing spondylitis, which causes back pain. And you can see here on the bottom, all of these symptoms she rated as severe on a symptom questionnaire that I gave her. So these symptoms led me to determine that hormone and neurotransmitter testing would be of benefit. So you can see here Molly's hormone report. Estradiol is at the top end of the reference interval for her age and menopausal status. This is likely upper range because we have elevated testosterone and DHEA, which can both influence estrogens. Progesterone is expected to be quite low in a postmenopausal female, and that, in fact, is what we see. And you can see that her cortisol levels are really skimming the bottom of the diurnal curve. And this is her NeuroBasic neurotransmitter report. So you can see we've essentially here got a lot of low levels, although the catecholamines, norepinephrine, epinephrine are pretty elevated. So we're going to take a break for Molly from right now. At this point, I'd like you to think about what you think might be appropriate for her. What might you do in your practice? And we're going to move on with the lecture, and then we'll revisit Molly at the end. And maybe there'll be some new ideas about how to address a patient like her. So if we honor the idea that the body has an inherent drive to heal itself, which is a naturopathic principle, and that is what my credentials are, we can help the body do this by removing what we call obstacles to cure. So things that inhibit the person from achieving optimal health. So an important one to consider is blood sugar imbalance. We know that when blood sugar or blood glucose levels drop too low in a healthy person, the adrenal glands release cortisol, which triggers the breakdown of glycogen stored in the liver and the muscles and releases glucose into the bloodstream. However, if a person's cortisol is low, that release of glycogen can't be sufficiently triggered to raise the blood sugar. And instead, the adrenal glands, the adrenal medulla, will release epinephrine and norepinephrine as a backup. So these are the 3 fight or flight substances that can cause a person to wake at 3 a.m. filled with anxiety, or maybe even to feel nauseated in the morning. We could do an entire lecture, really an entire weekend, on stress. And it's really important in this context as well. Chronic stress is a very significant obstacle to cure. It literally shrinks the brain and degrades the blood-brain barrier. Stress can be physiological, mental, emotional, or environmental. And you can see some examples listed here. Remember that excess adipose tissue, especially if it's that abdominal adiposity, is inflammatory. And so it is also a stressor. Chronic stress can damage the hippocampus, which is involved in driving the sleep-wake cycle. So stress is really, really, really harmful. It also causes elevations in many inflammatory cytokines, but IL-6 in particular, which is considered to be the most potent pro-inflammatory cytokine. And so that further enhances this sympathetic stress response. So for instance, there are studies that have shown that getting into a heated argument with your spouse will raise IL-6 levels, and this elevation can actually be seen for several days past that argument. This next example is more extreme, but the midbrain gets flooded with IL-6 during long periods of extreme stressors like war, or potentially a pandemic like COVID-19, which can make the body extremely sensitive to stimuli. So eventually something as benign as a loud sound or a flash of light can trigger an inappropriately huge stress response. So in essence, chronic stress and inflammation make the brain highly efficient at responding to stress. So when you see symptoms of neuroendocrine imbalance and stress is likely a contributor, it may be appropriate to look at the HPA axis and beyond. And in addition to adaptogens and glandulars and nutrients, which we often think about with HPA axis dysregulation, you may want to think about brain inflammation. So then you might consider additional therapeutics like dietary flavonoids, green tea, resveratrol, curcumin, melatonin. You can see there's a long list here of things you could consider. One of the most vital nutrients for the brain is oxygen. In order to get oxygen, our patients need healthy blood vessels and proper circulation. We know that stress can cause shallow breathing, which keeps the body in a state of fight or flight, and it shunts blood to the limbs, the heart, and the lungs. Other factors inhibiting oxygen to the brain may be things like anemia, smoking, low blood pressure or high blood pressure, poor lung function, poor cardiovascular function, obstructive sleep apnea, really any mechanism that impairs blood vessels. We may also think about something like diabetes. So consider all of these factors before choosing therapies that could be of little use if they aren't getting to the brain due to poor circulation. Digestion is a very big consideration. Please don't overlook it. The health of the GI, which allows for nutrient absorption, has a profound effect on neurotransmitters. And it's not just the ability to absorb nutrients, but it's also a site that is really common to find chronic inflammation, which hijacks neurotransmission. So people often ask me if neurotransmitter imbalance can be addressed with diet alone. And my answer is theoretically yes. But as you all know, when working in clinical practice, the lives of our patients and their physiology and biochemistry is really complex. They don't live in a vacuum where we can perfect their stress, their diet, their exercise regimens, their sleep, etc. So generally, apart from poorly practicing vegans and vegetarians who may be protein deprived, I think most people eat enough protein rich foods to supply the amino acid precursors that they need, but we still see imbalances. And so I've come to believe that the issue is not necessarily a lack of amino acids, but how they're being absorbed and how they're being utilized. We do know if someone is sensitive to a food and they continue to consume it, it will prevent optimal functioning. There's some common food sensitivities and food allergies. It doesn't have to be an allergy, just a sensitivity to it. And we think about things like milk, eggs, peanuts, soy, shellfish, corn, and gluten. This study looked at Americans in 1950 and also Americans in the year 2000. Their investigation found the prevalence of celiac disease increased dramatically in that 50 years from 1 in 700 to 1 in 100. Now, this study only evaluated celiac disease and not the less severe but more common gluten sensitivity. Over the years in the United States, gluten has been hybridized and deaminated, and these are processes that make it more inflammatory. Don't confuse this with genetic modification. This is a little bit different. Hybridization creates a new protein by combining different strains of wheat, and over time, this can alter a protein sequence by as much as 5%, which makes it quite different from the original source. Deamination makes wheat easier to use because it makes it more water soluble, so that it's easier in processed foods. But this has been shown to create a severe immune response in people. In a double-blind placebo-controlled trial, they found that subjects didn't react to native wheat flour, but they did react severely to deaminated wheat. The hybridization and deamination of wheat appear to play a role not only in the sharp increase of gluten sensitivity and celiac disease, but also in inflammation, degeneration, and even autoimmunity of the brain and the nervous system. Some studies indicate that gluten sensitivity destroys the brain and nervous tissue more than any other tissue in the body, including the GI. Doctor's Data offers both a serum and a blood spot test for testing for celiac and gluten sensitivity. And I just wanted to point that out as a resource for you. Untreated celiac disease can cause an array of nutrient deficiencies because the intestines are affected. So you can see here the normal villi in an intestine, and under the influence of celiac disease, they're blunted. And so all of that beautiful surface area that used to absorb nutrients is now gone. Studies show that even after a year of a gluten-free diet, malabsorption can still be an issue. And as someone who has to follow a gluten-free diet myself, I can tell you that incidental exposure happens a lot, even when people are being very careful, especially if you're going out of your own home to eat somewhere. So this is probably a problem for people who have issues with gluten sensitivity. Additionally, a lack of fortification in gluten-free products in people who rely on these foods might result in additional nutrient deficiencies if people aren't being careful about getting all the nutrients that they need from fruits and vegetables. If they're relying on processed carbohydrates, that can be a problem. Folate is very important because deficiency is associated with depression, a poor response to antibiotics, and a higher depression relapse rate. Folate supplementation actually enhances the effect of antidepressants. And it's pretty common for patients to be deficient in folate, not just with celiac disease. Look for other contributory factors like medications, things that are commonly used like birth control pills, metformin, SSRIs like fluoxetine. Diabetes and hypothyroidism can affect folate absorption, also alcohol intake, just the aging process, even obesity. Low folate status can make patients using SSRIs more likely to relapse. So this trial found that after 28 weeks of fluoxetine treatment at 20 milligrams a day, The relapse rate for patients with low folate levels was about 43%, but the relapse rate for patients with normal folate levels was only 3%. Folate deficiency, whether it's dietary, genetic, or drug-induced, can contribute to a variety of CNS disorders. So things like depression, dementia, seizures, developmental delays, neuropathy, myelopathy. I just found this visual to be helpful, and so I wanted to include it here for your reference. All right, let's move on to iron. Iron is important because it's a cofactor in the conversion of tryptophan to 5-hydroxytryptophan and tyrosine to L-DOPA. So here we've got a little snippet of the biochemical pathway of tryptophan moving downstream into 5-HTP, and you can see that iron is an important cofactor to make the tryptophan hydroxylase enzyme work appropriately. Iron deficiency anemia is common in cycling women, especially those who have heavy menses, but also anybody who has malabsorption issues, including gluten intolerance. Hypothyroidism can also impair the body's ability to absorb iron, and so can low hydrochloric acid. Serum zinc levels are inversely correlated to depression. Studies have looked at this. Women who took a multivitamin and zinc showed a significant reduction in anger, hostility, and depression. And patients who received 25 milligrams of zinc daily had significantly reduced Hamilton depression rating scores and Beck depression inventory scores compared to a placebo group. And here we have a meta-analysis of 17 studies supporting the idea that depression is associated with low zinc levels. So zinc is not just an idea for immunity or testosterone. We should be considering it for mental health as well. Doctors have understood the benefits of magnesium for a long time, all the way back in 1921, where we see the first documented study on this. Magnesium repletion is associated with improved mood, healthier eating, improved response to stress, and improved sleep. This study examined the relationship between magnesium intake and depression in almost 9,000 adults over about 4 years. And researchers found significant association between very low magnesium intake and depression, especially in younger adults. This is one of my favorite studies. I find it incredibly interesting. It's looking at nutrition and behavior. So it was a double-blind, placebo-controlled trial of nutritional supplements on 231 young adult prisoners, and they were comparing disciplinary offenses before and during supplementation for about 4 months. Now you can see here they were given a standard multivitamin mineral supplement as well as omega-3 and 6 components. And you can also see that the amount of EPA and DHA was quite modest. But those taking these supplements for a minimum of 2 weeks experienced on average a 35% reduction in offenses. Pretty amazing. Vitamin D controls transcription for over 1,000 genes involving the nervous system. Vitamin D is a cofactor for the production of serotonin and dopamine, and this is one theory as to the etiology of seasonal affective disorder. Vitamin D is typically lowest in the winter months and can result in depression. A lot of studies in the United States come from the military because the Veterans Administration has a large database of patients, and depression and suicide are a significant problem in active duty service members. In this case-controlled study of active duty service members, more than 30% had vitamin D levels below 20 nanograms per mil. So essentially, the lower the vitamin D status, the more likely they were at risk for suicidality. Okay, now let's pivot to the gut microbiome. We really can't say enough about this. Microorganisms outnumber human cells by 10 to 1. It makes up to 3% of our body mass. So for reference, if you had a 200-pound adult, that's 2 to 6 pounds of bacteria. More than 10,000 microbial species occupy the human ecosystem. We understand that the environment and diet during the first 3 years of life are crucial to establishing the microbiota and to fine-tune bacterial host symbiosis. And this then influences, the development of the immune and the neurological systems. So this is a little snippet from the front page of the GI 360 microbiome profile that Doctors Data offers. It's a gut microbiota DNA analysis tool that identifies and characterizes more than 45 targeted analytes across 6 phyla, and you can see those here around this web. It uses PCR, and it compares the patient's results to a characterized normobiotic reference population. The abundance and diversity of gastrointestinal bacteria provides an indication of gastrointestinal health, and any microbial imbalances can contribute to dysbiosis and other chronic disease states. So the web chart illustrates the degree to which an individual's imbalance deviates from normobiosis. So you can see here, if the web pulls out towards the red area, that's an abundance of this family, and if it pulls more towards the center, like we see here, that means they're moving to less optimal levels of that particular family. The dysbiosis index is calculated strictly from the results of the microbiome profile. There are scores between 1 to 5. Any score over 2 indicates dysbiosis. And in the diversity score, you actually want to be higher, because this is telling you if you have a good diversity in the number of species of the microbiome. So over the past decade or so, studies have demonstrated a bidirectional relationship between the gut microbiome and the brain. Sometimes this is called the gut-brain microbiome axis. We know that alterations in gut microbial composition are associated with changes in behaviors that are relevant to mood, pain, and cognition. Dysfunction in this axis has been implicated in stress-related disorders like depression, anxiety, IBS, and autism. And accumulating data indicates that the gut microbiota communicates with the CNS through neuroendocrine and immune pathways. Many microbiome studies in rodents and other animals have been performed. Some have used germ-free mice, some have used pathogen-free mice, and some have included stressors. The accumulating evidence indicates that treating animals with wide-spectrum antibiotics has been shown to affect behavior, for better or for worse. Pathogenic bacteria can induce anxiety-like behavior in animals. Fecal transplants alter behavior and even BMI to match the donor. And probiotics have been shown to decrease visceral pain, improve systemic immunity, and improve behavior in moods and stress-related psychiatric conditions. Taking probiotics can attenuate anxiety and depressive-like behaviors in experimental animal and human models, and this study outlines 3 possible mechanisms: the competitive exclusion of deleterious gut pathogens, a decrease in pro-inflammatory cytokines, and also communication with the CNS via vagal sensory fibers. So all of these proposed mechanisms can affect neurotransmitter secretion. Leaky gut. I'm sure you've all heard this term. What this is referring to is a lack of integrity of the tight junctions of the intestinal epithelium, and this causes inflammation and can activate the immune system. Circulating zonulin is a clinically useful marker of intestinal permeability, and with Doctors Data, you're able to test for zonulin in either serum or stool. Now, if you take one thing away from today's lecture, I hope it will be this: that chronic systemic inflammation is the enemy of health. We know that systemic inflammation releases cytokines, and these cytokines send messages across the blood-brain barrier to activate inflammation in the brain, which alters function and can destroy brain tissue. So think about, for instance, a person with gluten intolerance who's not eliminating the food, and they're feeling a lot of brain fog and maybe some mood changes. Likewise, inflammation in the brain can activate the body's immune system and trigger inflammation, which can manifest in joint pain, gut pain, skin disorders, etc. So in this case, you might think of someone who has a head injury and then they subsequently develop an autoimmune disease. The blood-brain barrier is designed to allow only nano-sized particles in or out as needed and to help keep unhealthy things out. but it's extremely vulnerable to inflammation. And we know that when these cytokine signals reach the brain, they have the capacity to influence the synthesis, release, and reuptake of neurotransmitters like serotonin, dopamine, and norepinephrine. More and more research supports the idea that depression, while a disease unto itself, may, at least in some cases, actually be a symptom of inflammation. We know that inflammation affects neurotransmitter metabolism, neuroendocrine function, and neural plasticity. Now, I love the title of this paper. It's called, So Depression is an Inflammatory Disease, but where does the inflammation come from? And that's the rub, right? We really have to try to identify the source of the inflammation, and this can be a challenge. But this paper outlines some of the areas that we shouldn't overlook. They focus on psychosocial stressors, poor diet, physical inactivity, obesity, smoking, altered gut permeability, atopy, dental caries, poor sleep, and vitamin D deficiency. Omegas are very important for structural integrity of the brain. About 60% of the dry weight of the brain is fat. Essential fatty acids are required for maintenance of optimal health, but they can't be synthesized by the body, and so we have to get them from our diets. Patients with inflammatory markers tend to be more responsive to treatment with EPA. Now, this next point is very important. Please remember, it can take at least 10 weeks for cellular membranes to recover after chronic omega deficiency. So what I take this to mean is don't let your patients quit omegas after a month or two telling you they're not working. Generally, when it comes to treatments that I'm choosing for brain health, I ask my patients to be willing to stick with me for at least 6 months before trying something else. This meta-analysis of 13 randomized placebo-controlled trials suggests that omega-3s are comparable to antidepressants in the treatment of depression. Sadly, low omega levels have been linked to increased suicides. This was a study of 800 U.S. servicemen and women who committed suicide between 2002 and 2008, and they compared those to 800 service people who did not commit suicide. Personnel with medical records showing low blood levels of DHA were 62% more likely to have been suicide victims than those who had higher omegas. It's common to get omegas and other nutrients from food. In fact, as functional medicine providers, we often quote Hippocrates, "Let food be thy medicine." But what food is he talking about? We know that some foods may be of particular benefit to those with depression. Generally, a high intake of vegetables, fruits, etc., are associated with a decreased risk of suicide. Increased fruit and vegetable intake, as well as fish, may decrease risk of depression. The Mediterranean diet is likely the most studied diet, and people who follow it tend to have better cognitive outcomes. It decreases the risk of dementia, cognitive decline, and even the conversion of that decline into Alzheimer's. Now, avoiding processed foods is usually a no-brainer, but what actually constitutes the right diet for our patients? Indigenous diets might provide a clue, but depending on where you are in the world, indigenous diets vary quite a bit. However, what they all have in common is they avoid simple sugars and carbs, and they include good fats. All right, we're going to shift gears now and move away from gastrointestinal health and towards the effects of hormones on the brain and neurotransmitter secretion, because research has elucidated some important neuroendocrine interactions, and we will start with thyroid. There's a significant association between thyroid hormones and mood. Clinical depression occurs in over 40% of hypothyroid patients. Subclinical hypothyroidism is a major risk factor for major depressive disorder. This trial found that 56% of subclinical hypothyroid patients suffered an episode of major depressive disorder. And antithyroid antibodies are present in between 9 and 20% of major depressive disorder sufferers. Thyroid hormones influence a lot of different neurotransmitters. When we think about dopamine, thyroid hormones have been shown to regulate the levels of dopamine receptors and the activity of tyrosine hydroxylase. So generally, if there's low thyroid, you're likely to find low dopamine. With serotonin, numerous studies have shown diminished serotonin activity and depression in hypothyroid patients that is reversible with thyroid hormone replacement therapy. And with glutamate, T3 can protect against glutamate toxicity. So T3 regulates extracellular glutamate levels by modulating the astrocytic glutamate transporters and promotes neuronal development and neuroprotection. If we think about GABA, hypothyroidism slows the GAD enzyme. That's the glutamate decarboxylase enzyme. And this is the one that converts glutamate to GABA. And T3 can actually increase that activity. So essentially, T3 can result in more GABA, which is parasympathetic. Myelination is important. Hypothyroidism is associated with delayed myelination, and thyroid hormones are known to regulate neuronal proliferation, synapse formation, and promote differentiation in astrocytes. In addition to overt thyroid dysfunction and subclinical hypothyroidism, simply the presence of thyroid antibodies have been associated with a higher risk of postpartum depression. So the authors state there is an excess of depressive symptoms in cases of depression overall in women who are thyroid antibody positive in the 8 months after delivery. This was true for all women with positive antibody status, regardless of whether they developed thyroid dysfunction. Patients with thyroid insufficiency are especially sensitive to developing depression. And I want to give you this treatment pearl. T3 treatment is also beneficial in euthyroid depressed patients. So people with a normally functioning thyroid gland can potentially also benefit from T3 therapy. And T3 can make antidepressant therapies work better. One theory behind this is that thyroid hormone directly affects activity of catecholaminergic enzymes and can increase the sensitivity of receptors. All right, moving on to sex hormones. There's some interesting research out there regarding how sex hormones affect the brain. The male brain is anatomically different than the female brain. Men have a larger hypothalamus than women. The female brain has more gray matter, which governs sensory perceptions and muscle control. Men have more white matter, which is essential for relaying information for cognitive function. The frontal lobe, which is our emotional control center and the neurological seat of our personality, also differs between the sexes. The male frontal lobe has more receptor sites for testosterone, whereas the female frontal lobe has more receptor sites for estrogen. The frontal lobe also generates motivation and drive, and it's common to see women with low estrogen and men with low testosterone suffer from depression and poor motivation. There have been some small but very interesting research into how sex change affects brain shape. Patients undergoing a sex change or a transition take large amounts of hormones to develop the characteristics of the gender they identify with. So researchers looked at the brain MRIs of these patients before, during, and after hormone treatment. In one study of 8 subjects undergoing a male to female transition and 6 subjects undergoing a female to male, researchers found that their brain shape changed. Males who were transitioning to females began developing more gray matter. Those receiving high amounts of male hormones developed a larger hypothalamus and more white matter. These are potent hormone doses we're talking about here, but in just 4 months, the subjects' brains actually changed to take on the shape and structure of the opposite sex. Many males that I test have either too much estrogen or too little testosterone, and many females are deficient in progesterone and have either too little or too much estrogen, and often too much testosterone. So I've started to wonder if these hormone shifts could potentially be changing the shapes of the brains and the way that they're responding to these neuroendocrine influences. Progesterone, via its metabolite allopregnanolone, has strong neurologic effects. The anxiolytic effects of allopregnanolone are mediated by the GABA A receptor. That's the same receptor that benzodiazepines target. And oral progesterone supplementation can potentiate this. So oral rather than transdermal, because oral progesterone on its first pass through the liver is metabolized in large part to allopregnanolone. This study indicates that serotonin levels drop in menopause, whether this is natural menopause or surgical menopause. And when estrogen therapy is utilized, serotonin levels go back to levels that were seen in menstruating women. And serotonin levels can also be low in amenorrheic women, women who aren't ovulating, essentially. Other studies have looked at perimenopausal and menopausal women who have less estradiol levels and complain of mood and cognitive concerns, but giving them estradiol reverses these symptoms. A primary mechanism seems to be monoamine oxidase inhibition. So let's take a look here at this pathway. So here's the monoamine oxidase enzyme that regulates the conversion from serotonin into its metabolite 5-HIAA. If this is inhibited, less is metabolized, and so more serotonin is available for use. Estradiol also increases the activity of the tryptophan hydroxylase enzyme, which is here. Now remember, we also discussed vitamin D and iron as being important for the function of that enzyme. In women, we often think about estradiol, but in men, testosterone is thought to be the most impactful hormone. Testosterone commonly decreases with age, which can result in changes in mood and mental state. So this was a rodent study. They found that giving testosterone could increase serotonin receptor sites, resulting in greater serotonin activity and improvement in cognition, mood, and mental state. Interestingly, estrogen also increased these binding sites. And this did not happen with DHT, dihydrotestosterone, which is the primary metabolite of testosterone, and it's a potent androgen in itself, but it cannot convert to estrogen. So this suggests that the action of testosterone in males may actually depend upon its conversion to estrogen by the aromatase enzyme. So my takeaway from this is that aromatase inhibition may need to be used with caution in males when mood is a concern. Minor fluctuations in dopamine can profoundly alter memory. Estradiol has been shown to enhance dopamine activity, which can affect memory and mood. The production of testosterone is controlled via a specific feedback loop called the hypothalamic pituitary gonadal axis. Researchers found that the administration of a dopamine agonist in rat brains increased the amount of GnRH messenger RNA by 67%, and that's involved in the DNA replication of GnRH. The hypothalamus secretes GnRH, which signals the pituitary gland to secrete LH, luteinizing hormone, which in turn signals the gonads to produce testosterone. So this was a very wordy way of saying that dopamine can help with testosterone secretion. And dopamine and testosterone seem to have a bidirectional relationship. Dopamine can influence testosterone, but testosterone can also influence dopamine. So it seems to be through this area called the medial preoptic area. One study found that micro-injecting dopamine agonists in the MPA of rats resulted in an increase of sexual activity. And another study observed that castrated male rats showed no interest in fornicating and no dopamine release in this medial preoptic area. But after testosterone injections, the castrated rats were able to engage in sexual intercourse and showed an increase in dopamine release in the MPA. Dopamine and serotonin can acutely stimulate testosterone production, but epinephrine can inhibit it. This is probably no surprise, right? If we think about being extremely stressed, the body and the brain is going to deprioritize sex. It's not as important as breathing, getting glucose to our muscles, that sort of thing. We're probably all familiar with the term roid rage. This is the idea that when men are taking too much testosterone supplementally, it can cause anger and aggression. Research indicates that this aggression is actually attenuated by serotonin. So in animal studies, animals with high testosterone and low serotonin had increased aggression. And these were primate studies. However, if the primates had adequate levels of serotonin, even when they had high testosterone, aggression and impulsive behaviors decreased. So what I think this tells us is that if we're using testosterone therapy and aggression is a side effect that your male patients are experiencing, test to make sure that their serotonin levels are adequate. And if not, we should be supporting that serotonin. This was a study of 4,000 depressed men who had low testosterone. And when they were given testosterone, their symptoms of depression improved. These studies didn't look at neurotransmitter secretion, but I did want to mention it because it talked about the benefits of testosterone therapy for depression. It can actually be pretty significant. All right, in summary, healthy estradiol levels improve serotonin and dopamine in both males and females, and this can improve mood and cognitive concerns. Allopregnanolone is anxiolytic due to the GABA-A receptor stimulation. Dopamine can enhance testosterone secretion in males. It's been examined in the context of sexual health, but because other studies have identified the role testosterone plays in mood in males, we can extrapolate that testosterone and dopamine are linked and can therefore improve cognition, mood, and energy. And also, serotonin will attenuate aggression that can be seen with testosterone therapy. All right, now let's move over to the stress response and the cortisol neurotransmitter and various neurotransmitters that are involved in that stress response. So we all know in response to a stressor, our body immediately releases epinephrine and norepinephrine, and then moments later, cortisol is released. And all of these together allow us to freeze, to fight, or to flee the danger. You may not know that serotonin actually has an essential role in this cascade as well. So in the presence of stress, serotonin and acetylcholine, but we can't test for acetylcholine because it degrades too quickly. So we're focusing on serotonin here. So in the presence of stress, serotonin tells the hypothalamus to secrete CRH, corticotropin releasing hormone. And CRH stimulates ACTH, which stimulates cortisol secretion. So if cortisol is inadequate, these signals may be compromised. Chronic stress eventually leads to depletion of the catecholamines. Now, the catecholamines are dopamine, epinephrine, and norepinephrine. And depletion of these catecholamines is closely related to stress-induced performance decline. So issues with focus, energy, motivation, mood. So when I think about stress and how it affects physiology, I like to think about it in terms of there being 3 stages. So the symptoms that patients present with, no matter where they are in these phases, may look really, really similar. They can present as tired, as moody, having brain fog, not sleeping well. And patients all move through these various stages of stress at various rates. So this is why I think testing is really important. If we test a patient in an early stage, generally this is what we see on testing. Often you'll find these patients do have energy still, even though they're feeling stressed. The body is really good at responding to stress for a period of time. So these patients may tell you they're not feeling great, they're feeling stressed, but they're generally still able to get through their day and get everything done. So in these early phases, what we'll often see is an increased cortisol at 1 or 4 points throughout the day and increases in epinephrine and norepinephrine. But the sympathetic nervous system isn't designed to stay in high stress mode without a break over the course of months or years. This is what we might sometimes refer to as adrenal fatigue. But I do want to remind everybody, the adrenal gland isn't actually fatiguing. This is kind of slang for this concept, but our patients may use this term. So just to make sure we all understand what we're talking about, really what this is the sympathetic response and the HPA axis adapting to this constant onslaught of stressful stimuli. So what happens is eventually it begins to down-regulate. So in this phase 2 stage, we might find that some neurotransmitters test high and others low. some may be holding on for the moment. So what I often find in this stage is that the cortisol curve will be suboptimal, especially if that AM cortisol level is starting to decline. That's significant because that's the highest point of cortisol over a 24-hour period, or ideally it should be. These patients may start to complain of fatigue, impaired cognition. They may still have some energy, but they may also be feeling burned out. There could be depression and anxiety. For the catecholamines, you may start to see some slippage. Now, I have just observed, this is not in any sort of scientific study, but I have observed through looking at so many tens of thousands of these over the years that the neurotransmitter that seems to hold on the longest is epinephrine because it is so important to the stress response. But eventually our patients become very depleted and exhausted. This is phase 3 or late stage. Generally at this point, our patients really don't feel well at all. Because cortisol, norepinephrine, and epinephrine are all key players in the stress response. When patients are depleted, there's just really no gas in the tank. And these people generally feel pretty crummy. Because everyone living on planet Earth today is dealing with some degree of stress, whether it's environmental or physiological or relationship, I think it can be really important to test cortisol and neurotransmitters together. All right, I did want to quickly talk about how neurotransmitters are involved in metabolic syndrome because that's such a common issue now. Metabolic syndrome, as we know, is a state of sympathetic nerve hyperactivity. This study suggests that insulin and norepinephrine cooperate independently to the development of metabolic syndrome, and both are often increased in metabolic syndrome. So the criteria to diagnose metabolic syndrome are listed here. Insulin and catecholamines likely cooperate to the development and clinical features of metabolic syndrome. Insulin seems to be the determinant for the negative metabolic aspects, whereas catecholamines seem to be important for the development of hypertension and impaired glucose metabolism. All right, so let's revisit Molly. So remember Molly, these were her symptoms, right? Gaining weight, hot flashes, insomnia, fatigue, cognitive complaints, depression, anxiety, poor libido, gas and bloating, ankylosing spondylitis, feeling pretty crummy. So when I tested her salivary hormone levels, I found estrogen dominance, aka progesterone insufficiency. So you can see here, she's menopausal. We might expect progesterone to be low. In fact, it's even below the low reference interval for menopausal women. And her progesterone to estradiol ratio at 5.3 is significantly less than what we would expect to see. Now, a quick caveat here. The progesterone to estradiol ratio is not a physiological ratio. It's more of a clinical ratio. It was developed by Dr. John Lee, who was looking at the benefits of progesterone for hot flashes, night sweats, bone density, and that sort of thing. So cycling women, because they're making progesterone, can get there on their own. Postmenopausal women and men require supplementation. And so that's why there's no reference interval for this ratio in a postmenopausal woman, but there is a supplementation range that we can shoot for. You can see here she has elevated androgens. So this isn't a hormone talk, but just as a reminder, if someone is dealing with dysglycemia, metabolic syndrome, insulin resistance, we'll often see androgens be elevated in our female patients. Generally, what we see in male patients is that these things, particularly testosterone, will actually decline. But in females, they're elevated if there's issues with insulin resistance and dysglycemia. And her cortisol secretion, you can see here, is pretty puny. So this is what we call phase 3. For her neurotransmitters, these imbalances are in line with her reported symptoms. The low range serotonin and low dopamine are associated with the mood concerns and decreased cognitive abilities in her cravings. The upper range norepinephrine and epinephrine are associated with anxiety, agitation, irritability, insomnia, and lack of mental focus. Upper range glutamate may be contributing to anxiety, poor concentration and attention deficits, and nighttime waking. Low GABA can be associated with anxiety and decreased sleep quality. Low histamine can affect learning, memory, and mood, and low PEA, phenethylamine, is associated with cognitive concerns. The upper range norepinephrine, as we just learned, is associated with metabolic syndrome, and this also played out in her blood work. Of course, it can also be associated with stress. So some other pertinent labs and physical findings, you can see her blood pressure is slightly elevated. Her trigs are a little high, LDL a little high, HDL a little low. Hemoglobin A1C suggests pre-diabetes, in my opinion. So does the fasting glucose of 92, and her vitamin D is suboptimal. So essentially, because her BP is a smidge high, her lipids and glucose levels are not optimal, we have, in my opinion, a case of metabolic syndrome. So if we think about Molly, this is what I think are her obstacles to cure. And these should look familiar to all of us now, right? We've got inflammation, and this is likely coming from the fact that she's obese and from her ankylosing spondylitis. She has diarrhea, so likely inflammation in her gut and potentially food sensitivities and dysbiosis. She has blood sugar imbalances, estrogen dominance, stress, vitamin D insufficient. And so now that we know all of this and how it can affect neurotransmitters, you may not be surprised if we thought we could give Molly some 5-HTP and it didn't quite fix everything. Okay, so the therapeutics that I chose. So to address the estrogen dominance, I use progesterone supplementation, transdermal, 30 milligrams twice a day. Twice a day because she has vasomotor symptoms, hot flashes and night sweats. The fluctuation in hormone levels are often as much of a contributor to hot flashes and night sweats as imbalanced hormone levels themselves. And so twice a day dosing typically results in a little bit of a steadier state than just giving hormones once a day. To address the dysglycemia that she has exhibited, which we saw on blood work, but also that's reflected in these elevated androgens, I recommended that she eat a diet that had less simple carbs, more of a protein-forward diet. You might call it paleo. Also vitamin C, chromium, NAC, and cinnamon. For her HPA axis dysregulation, there was a formulation that contained some good adaptogenic herbs, as well as some vitamins and nutrients. And I dosed that 2 caps in the morning and 1 cap at noon. And if hydrocortisone is available to you, you could give it at physiological dosages. Generally, we're trying to avoid giving more than 20 milligrams a day. So 10 milligrams in the morning and 5 at noon is a consideration. For the neurotransmitter imbalance, when we think about, so PEA, phenethylamine, this neurotransmitter, and again, if this is brand new to you, I recommend you go back and see my January lecture on neurotransmitters that is archived on the Nordic database. But PEA is very closely associated with memory and cognition issues. So when this is low, this is definitely something we want to address. But PEA is made from phenylalanine, and so are the catecholamines, dopamine, epinephrine, and norepinephrine. So you could think about giving tryptophan for the low dopamine, but backing up and giving phenylalanine because it's at the top of that biochemical cascade allows you to sort of get a twofer, boost PEA and dopamine with one support. B complex with activated forms, because B vitamins are essential cofactors in many of these biochemical conversions and pathways. L-theanine is added because it's sort of a modulator. We think about it sort of as being an adaptogen in the system. It can sort of boost things that are low and blunt things that are high. But additionally, therapeutically, it's really, really beneficial for anxiety. And also for anxiety, I gave her this anxiolytic herbal tincture that she could use as needed. 5-HTP for serotonin support, GABA for GABA support, and L-histidine to support the low histamine. Other treatments, vitamin D, probiotics, fish oil, Melatonin, I gave her a slow release at bedtime because she was able to fall asleep pretty well, but she wasn't staying asleep, and slow release can help patients stay asleep better than immediate release can. Also, that anti-inflammatory low-carb diet and exercise, super important. This is the bare minimum, 30 minutes, 5 days per week. But with patients who aren't exercising, that can feel like a lot. So we want to start low and go slow. Also, because of her ankylosing spondylitis, we want to try to avoid vertebral fusion. And so I encouraged, in addition to cardio, that Molly start to do stretching and yoga to keep her joints mobile. So 4 months later, we did repeat hormone testing. So generally, I check in about 3 months after starting hormone therapy to see if the doses that I chose are appropriate. And so you can see here that if we just look at testing, Molly's looking more balanced. That low progesterone is up, and the ratio between estradiol and progesterone looks good. Testosterone has come down from 58 to 51, so still a little high, but moving in the right direction. And the DHEA is now within the reference interval, and our cortisol curve is much improved. But when I check in with Molly, she says some of her symptoms have improved, but she still is having mood concerns, sleep issues, gas and bloating, and cognitive concerns. So at the 6-month mark, I retested her neurotransmitters. I generally don't like to retest before about 6 months because I think it can take that amount of time to see changes here on lab work. Patients often feel improvement faster, but 6 months is generally when I retest neurotransmitters. So you can see here, there has been some improvement in these upper range catecholamines. So the norepinephrine and epinephrine that were on the higher end now are low, but none of these low levels have improved. We've still got everything looking really, really low. So what's going on? Besides the hormones and neurotransmitters, her symptoms point to there possibly being an issue with her gut health. So I started to think, well, I'm giving her all these great supplements, then she's taking them, compliance is good, but maybe she's not absorbing them. So I decided to do more testing. So this was the result of her GI 360. Now, remember, this web chart illustrates the degree to which Molly's microbiome profile is deviating from normobiosis. So Firmicutes is low, Proteobacteria is high. So you can see it pulls out when there's a lot, pulls in when there's not enough. And her dysbiosis index score is 3. Anything over a 2 indicates dysbiosis. So her score was 3. And we saw dysbiotic and pathogenic bacteria, yeast, parasites, and viruses. Those you'll see when we pop into the report. Those are reported separately, but Molly did have some interesting findings. So we'll start here. The fecal pH is largely dependent on fermentation of fiber by beneficial flora. And so a low pH is likely due to the dysbiosis that she is exhibiting. She's eating a protein-forward diet. She may not have been getting the amount of fiber that she needs. Klebsiella here is a 4+. It's a normal finding in a lot of people, but if it's present at 3+ or 4+, it's considered dysbiotic. And overgrowth can cause gas and bloating, and it's been linked, interestingly, to ankylosing spondylitis. Patients who have ankylosing spondylitis usually have larger amounts of Klebsiella than their non-ankylosing spondylitis counterparts. The worsening of diarrhea and bloating with ingestion of sugar is consistent with the finding of 3 strains of Candida. And you can see here with 3 samples tested, Molly has a parasite. It's Dientamoeba fragilis, and it's wreaking havoc. You know, if we don't know how long she's had this issue with parasite, but if we look at her secretory IgA level, that is trending very low. So generally with secretory IgA, what we see is elevations when patients are first infected with something. It's that stress response. But if the infection goes on for a long time, generally what we see is a depletion in secretory IgA. And so I suspect that this parasite has been around for a while. And if they're not treated, parasites can cause a lot of damage to the intestinal lining. It's just sort of a constant inflammation, and that can contribute to illness and fatigue. So one of the things I like about this test is it has susceptibility testing, which can give me great guidance for choosing my therapy. So when we look at the Klebsiella here, you can see in Molly's case that berberine and black walnut had low susceptibility, so they would not be good choices for treating the Klebsiella, and also ampicillin. She's resistant to that. So none of those would be good choices for her. If we look at the 3 strains of Candida, you can see here, berberine is a good choice in this case, but not in this case. So probably not one that we would do, but say grapefruit seed extract, right? That is susceptible in all 3. So that might be a therapeutic that you would try. So as a general rule, if you're thinking about treatment, it's recommended that you consider 1 or 2 of the top naturals, and you would use that for 4 to 6 weeks per the manufacturer's instruction, or you could choose one of the prescriptive agents. So here's the treatments that we settled on to treat the Dientamoeba fragilis. The standard of care, at least here in the States, is iodoquinol, 650 milligrams 3 times a day for 20 days. It's a pretty brutal treatment, but it'll take care of it. For the yeast and Klebsiella, grapefruit seed extract was a good option across all of that susceptibility testing, and so that's what we did. Molly had been doing well with her paleo-style diet, but she had been on this diet for a while, and she'd lost some weight. And at this point, because we saw the dysbiosis, I counseled her to start being really cognizant about adding in fiber. And I mean, essentially fruit and vegetable fiber, and maybe some complex gluten-free grains. Soluble fiber in particular has a really nice influence on microbiome health. So after those interventions, we retested neurotransmitters at the 12-month mark, and you can see finally we're getting somewhere. The difference in the tests are significant, and Molly is feeling better. This was a 12-month follow-up for that GI 360. We can see now we have good diversity, abundance is better. I'll continue to stress fiber in the form of legumes and fruits and veggies, but we see great improvement here. The dysbiosis score indicates this gut is now normobiotic. The pH and the secretory IgA are now within normal limits, and the Dientamoeba parasite is gone, and the yeast is gone. Okay, at this point, 12 months later, Molly has lost 39 pounds. Her hot flashes are better, her insomnia is improved, her fatigue's improved, alternating constipation and diarrhea much better, stools now well formed, and gas and bloating are nearly gone. Additionally, she reports being in less discomfort from her back and her neck and has greater range of motion. So you can see here, I'm going to continue some of the hormone supplements, many of the neurotransmitter supplements, things like probiotics and fish oil, which are often something I'll do for the long term because people, I think, struggle to get these things adequately from diet. But focusing on that well-balanced diet and exercise. I'm going to half the amount of vitamin D. And at this point, I felt like we were able to discontinue the daily use of the anxiolytic tincture. She could use it as needed, but she didn't seem to need it so much. The dysglycemia formula, the hydrocortisone, because cortisol had improved so much, and all gut support other than the dietary recommendations and probiotics. So all of those antimicrobial herbs that we were using, like the grapefruit seed extract, those could be discontinued. So you might want to save this slide for your reference, because remember, as we've discussed today, addressing neurotransmitter imbalance is not just about boosting amino acid precursors. There are many, many things to consider. And when we're trying to make these changes with our patients, we really are asking a lot of them. So I do want to encourage you to be gentle with them, be patient with them. I find it's helpful to educate them as to why I'm asking them to make these changes, because these changes are simple, but they're not easy. So in conclusion, testing is not a magic bullet. There are complex interactions between hormones and neurotransmitters, and it's important to remove obstacles to cure when addressing hormone and neurotransmitter imbalances. A holistic approach is the most likely to result in good patient outcomes. Test for motivation, goal setting, quantification, progress tracking, and follow-up. All right. Thank you so much for your attention.
And thank you.
Hopefully we have time for questions. And
Yeah.
Catherine, would you like me to stop sharing or should I keep this slide up?
That's up to you. We can still see your face on the side, but
Okay.
so I put down a few. First, one came up in regards to the variation in the different neurotransmitters during a 24-hour period. Like I know you do like either morning void or you do a 24-hour full collection.
Yeah, both are options. So the I generally prefer spot testing, that AM collection, unless my patient has issues with kidney function. If you have a patient with kidney disorder, you have to do 24-hour because creatinine levels are so variable. But in healthy kidney patients, you can do it a morning spot. And the reason I prefer it is because we do recommend, and this is all in the instructions, but there are certain foods you have to avoid for 48 hours before testing. And these are foods that have shown in the research to significantly impact specifically serotonin and catecholamines. So bananas, avocados, tomatoes, wine, chocolate, aged cheese. This is the diet I like to eat generally, but I have to avoid these things if I'm going to test neurotransmitters, because if I eat these foods too close to testing, it's going to influence serotonin and catecholamines because of the food. So we're essentially testing the foods instead of the endogenous levels. So think of it kind of like if you have to go in for a fasting glucose. If you ate a bunch of pancakes with syrup before you had your glucose level drawn, it would reflect that breakfast rather than your endogenous secretion. So we're trying to control for that by avoiding these foods for 48 hours. And we also recommend patients avoid things like caffeinated beverages, nicotine, if possible, for the period before, like one day before. And so that way we can take that AM sample and then the patient can go about their day. And that AM sample, we hope generally it's the first void of the morning or the second void, but first void is great. And in fact, I find it preferable because it allows me to have a cup of coffee later. I'm less likely to get in a fight with my children if I'm collecting right when I get up in the morning. I'm not going to get stuck in traffic before I collect that first morning value. So all of these stressful things that can influence our neurotransmitter secretion are controlled for a little bit better with that AM collection. But having said that, some people like to see what the influences of the day in the regular foods we're eating. So you still want to try to avoid those specific foods that can influence specific neurotransmitters. But as a general rule, our diet and our daily activities will affect neurotransmitter secretion. And so the ranges are a little bit different for 24-hour collection because that one takes into account the things that someone is coming into contact with over the course of the day. So they're really similar, but as a general rule, I do prefer that AM one because I feel like I'm a little bit able to control for those influences better. I hope that made sense.
Amazing. Yeah, it does, at least to me. I'm sure the rest of you out there. So the other one was a question, and I guess your presentation kind of like demonstrates it, but one is asking about GABA, taurine, L-theanine in relation to tics and Tourette's, and like if you have any comments, like the gut needs looking at as well, and the diet and blood sugar and.
Yeah, I don't know about research like big trials that have shown benefits. So let me back up a little bit. So those amino acids that were mentioned, taurine, GABA, L-theanine, glycine, these types of things are inhibitory. They're parasympathetic. They can generally calm down excess excitability in the nervous system. And when we think about tics and Tourette's, research indicates that is associated with more excitability. There is also research into things like seizure disorders that seems to show there's more glutamate activity in these disorders, and glutamate is the primary excitatory neurotransmitter. So theoretically, bringing in more of these factors that can promote inhibition could be helpful. And that's sort of in theory. Like, I encourage you to try it. It makes sense to me theoretically. I don't know that there have been a lot of studies that have shown the outcomes of patients who are just using these types of amino acid therapies. And again, like Anne Catherine mentioned, I think thinking about these in a very monotherapy type way would be a mistake, because the influence of inflammation, of all these different things that we talked about today, is significant. So think holistically. And all of you who are attending here today, I'm sure, tend to do that because you're functional medicine docs. And so if we think about treating the whole person and maybe using those parasympathetic type amino acid therapies as well, you may see some improvement.
Excellent. Then a question came up, and I just took notes. I may not have, but it was like the low copper in regards to thyroid hormones and glutamate decarboxylase. It was in relation to taking zinc supplements that you get like a low copper or like
A low, does zinc affect glutamate acid decarboxylase?
Okay, I don't know. I'm asking because I didn't know the answer.
Okay. Because I don't really understand the question, go back and review those slides. Zinc is super important for neurotransmitter secretion. So I think zinc is a nice addition to most protocols, but do be mindful that zinc can deplete copper, and copper is an important cofactor in the conversion of dopamine into norepinephrine. That's the dopamine beta hydroxylase enzyme. And so you could overdo it with zinc if you're not giving copper, or vice versa. So that's an important little homeostatic point.
Just back to can you comment on the copper dependence of thyroid hormones and glutamate decarboxylase? Seems copper is often low in those supplementing with zinc, obviously.
GABA is low in patients supplementing with zinc?
No. I don't know. It doesn't say. It just seems like copper is often low in those supplementing with zinc. Maybe Afifa, you can put. It was Afifa's question, so it seemed like we don't really understand the question.
Well, if you feel like that's something you're observing, it may be that patient is not a great candidate for zinc.
Yeah. Okay. Then one question about the progesterone dosage, that it seemed high, the 30 milligrams twice a day, as in huge.
Mm-hmm. Oh, did you feel like that was huge? That's interesting. Okay. So this is how
someone did. So
this is how I generally make that determination. So with transdermal progesterone, I choose my dosages based on the patient's weight. And this is for females. So if she weighs 150 pounds or less, I generally consider 30 milligrams per day to be adequate. And if she weighs more than 150, I may double it. And Molly was in the obese category, so her body habitus was bigger. And because her hot flashes were so significant, I was giving 30 milligrams twice per day. And if you find that is too much in your patients, then certainly you can be more conservative. That is probably about as aggressive as I get in terms of my dosing. So generally it's sort of 20 to 30 milligrams if she's smaller, 40 to 60 if she's got more body mass.
Super. And then in regards to this progesterone, what about the second pass effect of progesterone? I'm not sure that makes.
Yeah, if you're thinking about allopregnanolone, it's an interesting point. So if we swallow progesterone, as I was saying, it has a very large first pass effect. We estimate in some patients up to 90% of the progesterone that they're swallowing seems to be converted to allopregnanolone. So if you're trying to make allopregnanolone, which can be helpful for anxiety and insomnia in particular, oral progesterone is my preferred way to do it. But I don't find that it's the best way to raise tissue levels, Now, this is setting aside the controversy about whether transdermal progesterone protects the endometrium. Most of the studies out there show that oral progesterone needed to protect the endometrium, and we're not going to get into that today. Transdermal progesterone is absorbed in its original form, and it goes to the tissues before it goes to the liver. So there is a second pass effect, but a lot of the progesterone has been absorbed by the tissues before it goes to the liver. And then that second pass does get converted to allopregnanolone, but there's less because so much of the progesterone has already been absorbed. So hopefully that answers the question you were trying to ask.
I think it does. And I think that's kind of, no, there was one who that's perhaps more like a general question, because she kept asking in the case that you have presented, you've chosen like a lot of supplements, and how would you prioritize 5 if you were to?
Well, if I could go back and do it again, I would have tested Molly's gut first. Now I almost always now I almost always test someone's gut as a matter of course. If you're going to see me as a patient, we're going to do it, because over the years I have come to learn how much gastrointestinal health affects everything else. So today's Dr. Ferris would have tested her gut first, and we could have done a lot with diet, with stress management techniques that maybe didn't require adaptogens or hydrocortisone, with exercise. Exercise is so powerful if we can get people to do it. And then I may have just needed to use some antimicrobial agents to address the problematic pathogens. Then she may have started to feel a lot better, and we could have moved on to the hormone and neurotransmitter support, but she may not have needed as much neurotransmitter support if I had addressed the gut first. As a postmenopausal woman, she needs progesterone because she's not going to make it in any significant quantities anymore. So that's one I think that's difficult to avoid. But if we could get patients to eat better, move their bodies more, sleep, and have a healthier, gentler view of themselves in the world, I think that's huge, and it doesn't cost any money at all. That's just the challenge, isn't it? I mean, we're all so busy, we're so burnt out. Sometimes it takes supplements to get people to a point where they feel motivated and energetic enough to make the lifestyle changes that have the most profound effect. So I guess that's my take home here. Mm-hmm. I think testing for gut health is, I think you could argue that it would be the most important test you could do for anybody as the first test. And then you can address that first and then move on from there. But, I kind of think of health as like a choose your own adventure book. Do you remember those? I mean, I'm dating myself. I'm a Gen Xer, but when I was a kid, you could do that, and you could kind of go in at any chapter and kind of choose your way. And I think when it comes to medicine, it's kind of a similar approach. Like, we could enter our interventions, start our patient support at chapter 1, 2, 3, 4, or 5, and you're probably going to have great success no matter where you enter. But arguably, there may be some places that you enter that would be a little bit more efficient at getting the patient to that endpoint than other places. And I think GI health is actually probably the best place to start.
Excellent. With that note, I think it's, well, at least us in Europe, have a lovely evening. And you, Lylan, thank you for for such a hectic morning of yours. And I wish you a beautiful day over there.
Thank you. Thank you, Anne Catherine.
Hope to see you soon. Thank you, everyone, for joining and hanging in there. Thank you. Bye.
Good night, everyone.
If you do not already have an account with us, please contact our team and we will assist you. If you found this webinar helpful, please like and subscribe to our channel.